be surprised how much a vein graft will support. And you know, there are things to be gained from a vein graft in that you get a good seal. We can't prove that that's necessary, but your brain tells you that it's a good idea, and it will support the weight of the prosthesis. And there are disadvantages. You can't see where the hole is. So you pay your money, as we say in the UK, and you take your choice. But at the moment, we can't prove that a vein graft is necessary. I have a very simplistic way of looking at it, is when my BMW is rebuilt, I want a cylinder head gasket to stop the oil leaking out, but I can't prove statistically that the vein graft's important. Wilco might be able to tell you.
You're babbling.
I'm not babbling. It's how you think about it. You tell us, is it necessary to have a seal?
I think it's necessary to have a seal on your BMW. Nobody knows, really. All we know that the results done in this clinic are fantastic. So I think maybe it's wise to look more at this technique, because the results are fantastic. Both with the vein graft, anyway. With this slightly bigger hole than we normally have, the vein graft apparently may put some...
So, Robert, what do the aviation authorities say in France?
No, I think the vein graft, you know, it's not a question of success rate with the vein graft. Personally, I don't think the difference in success rate is related to the fact that you use or not a vein graft. You can achieve a perfect success rate post-op without vein graft. I really think the only point with the vein is a kind of security. When I want to seal something, I prefer sealing the opening with a large tissue rather than just picking up some connective tissue post-op. I think the most important thing, and we disagree with Wilco, we disagree. But I say the truth, you're a liar. It's different. It's in terms of distance and measurement. This guy doesn't believe in this. So he tried to understand why I get better results than he gets. He's the same surgeon as me. He's got a good experience. He's a great surgeon. He's perfect with his hands. So it's not related. Stop it. But the main difference is that he does not measure. No. Never. So he's using all the time a 4.5 millimeter length piston, which works in 75% or 80% of cases. If I look to my database, I put every detail inside since the beginning. So with more than 5,000 patients, I know the average length, which is true, 4.5. But we have cases in which it's less than 4 and more than 5, even on primary. So of course, it will fail. And this is why sometimes you can get 10, 15% difference in terms. So he doesn't believe in this, so he tries to find other way of turning around the right way. But the main cause is this, I'm sure. You improve your results in otology. I'm talking about functional surgery. We improve our results if we work into details in terms of measuring placement of a prosthesis. If we are not happy, we remove the prosthesis, put another one. That makes a huge difference, I think. You know, this is the main point. More important than the vein.
Okay, Robert, can I answer now?
No, that's
yes,
fine. We're finished.
No, the thing is, it's true that we don't really measure, but what happens? No. No. Let me explain to you, because what we do, we put the prosthesis in. And you can judge very well when the prosthesis is in. And the residents are very happy when I take one out and give it to them and say, okay, this size is wrong. So we do have a certain percentage that we do take out because they're not right. So we measure actually by the position of the prosthesis. Robert is right with the vein graft. Who does a vein graft in Stapes Surgery? Really? Are there any non-English French doing this? Don't put your hand up. So, no. And who always measures the distance?
Oh, a minority there.
No, it's still a minority.
So the European economy, despite being dependent on the Greek and the Germans, is dependent on the Dutch not letting water in, and you're guessing. You're guessing.
When in your kitchen, if you want to place something between two walls, yes, do you measure or not?
I have someone.
It's a very simple question. Do you measure or not?
Let me answer. I'll have someone do it.
So one final one to Thomas.
Oh, yeah, yes, John,
Thomas,
go on.
would you scuba dive with a Stapes?
That's a good question, and this might change my mind over the next weeks or years, because what I would like to ask another question to you instead of I wouldn't have this patient scuba diving for sure not, but I wonder whether you have seen patients having a late when landing with the plane 5-10 years later losing hearing. Well, I've seen it too. A couple of cases in so many cases. So if you have honestly never seen?
Honestly, I don't remember.
Honestly, I don't measure. Honestly, I don't remember. Yes.
I don't say it never happens because I'm not sure about that.
Yes, of course. Because this could change my mind in interposition, because people are traveling more and more nowadays than they were in the past. Everybody is going to take a plane at a certain moment, and we see from time to time people when coming back from holiday, they have a sudden hearing loss, and it's certainly due to this piston going into the labyrinth. It must be something like that.
Or
so
air.
if this vein can prevent this, I would be willing to start using it,
But nobody knows.
but nobody knows.
Thomas,
The pressure.
when you do what we call without, right? You have to do it by
When you do your technique, you do the technique what is so-called without interposition, right? How do you proceed? You put your prosthesis and that's all, or do you seal with some residual vein, tissue or blood?
Depends.
Nothing. But that's a real without interposition technique. That's fine.
Will be blood anyway. It will always be bleeding a little bit, and you will have the endothelium of the larynx will pierce it in across the brain. No, but this is a natural process of
But the pressure changes as well in an aircraft are tiny compared with the pressure changes diving. In terms of the speed of change. And I'm very wary about patients diving, but I do let them dive.
Now,
Yeah.
I have a microphone. I have a stewardess.
Well, you don't have to go into all the details.
I didn't have her.
KLM, obviously.
And the question is whether it's the pressure or whether it's at one point air entering into the cochlea. I don't know.
Yes.
Well, when blowing their ears.
Yeah.
So it's very difficult to say. I think your perforation in the foot plate is bigger than the perforation I make. I don't make a 0.7 perforation, but I don't do it in precision. And
So
I'm pretty
pressure
sure
gets through a big hole more than it gets through a small hole. You know that's rubbish.
we know that.
I'm not going to use the word.
flow.
This is rubbish.
Which diameter you use for the
I
for the stapedotomy?
0.5.
Yeah.
So you make a 0.5, but which diameter of? Yeah, but which drill do you use for that? Oh, you pick. Ah. Okay. So you have a 0.5 millimeter diameter pick. Okay, that's fine. That's fine.
So, John, with regard to your comment about diving pressure being higher than flying pressure, that's only relevant if you believe the fistula occurs from the inside out. If it occurs from the outside in, most of the eardrum change in the first half centimeter, half atmosphere. So after that, doesn't matter. It only goes half of that.
No, that's a pretty complicated for John. Try.
But most of the eardrum change will happen in the first fast. Yeah, so so you can get just as big excursions in flying as in diving of the eardrum.
So I ask you guys, you two guys, you're going to sit on the bottom in a 5-meter pool with your aqualung on. Do you want a vein graft or do you not want a vein graft, or don't you want to go in the pool in the first place?
John, is this the same strange analogy with the gaskets of your BMW? You don't have a gasket, BMW anyway, but doesn't make sense.
Okay.
You're with me, eh? You're my guest, so you.
Robert is my friend. So I just got a text actually from Bradford, UK, so we should all say hi to Chris Rain, and that people are really watching this live on the internet, which is exciting. I like to be a little provocative. And I don't put a seal either. I stopped putting a seal on. And when you go back and do revision surgery, there's always a good fibrotic seal, and that comes, and if you were to talk to John House or Howard House about that, it would be a blood seal leading to fibrosis. And so routinely on a revision, I need a laser to free up the soft tissue so I can see the stapedotomy. The other thing that I challenge on a revision stapes is there is a technique to actually leave the incus, the eroded incus in place, not relocate the malleus, and that's this, which I did not believe in 6 months ago, and I've now used it on 6 cases, which is this MVP prosthesis. And what I think that, I'll see the results, and I'm not going to even present any results until they're a couple of years out, but you still maintain an intact ossicular chain with the exception of the incusopedial joint. And part of what goes on, if there is movement of the stapes prosthesis, is the stability from the ossicular chain can prevent that from being sucked in, if indeed sucking in is the problem. And I think what Manhar said, which is very important, is the complications I've seen from people with stapes occur in swimming pools, not diving tanks, because the first atmosphere, the first atmosphere is in the first 10 meters. So it's almost a fallacy to say you cannot dive, but you can dive into a swimming pool, because it's getting a large pressure change. So.
Can I just have a question, Doug? What is the policy in the US for the pilot? I'm talking about in the Army or in the civil? Because we have a policy here, I'll let you know, but what is the policy in the US?
So there's an otologist who works with the FAA, David Shaw from Chicago, and I had this conversation with David because I have a lot of pilots in Seattle. And it's a case-by-case basis. And the pressurization of the average commercial airliner is 9,000 feet. And you can actually take a patient in a hyperbaric chamber to 9,000 feet quite easily and do it repetitively. You can even bounce them and see if they get any reaction. And I also have a stapes patient who flies an A6 Prowler aircraft for the Navy and has to land and take off an aircraft carrier.
Okay.
And we tested him and he did fine. So he's still fine. I didn't do a stapedotomy, so.
We have a policy in France. They are allowed now to have surgery if they have otosclerosis, but they need to go for a stapedotomy. That's the first point.
Stapedectomy.
Stapedectomy.
Right.
And, well, for the moment, no. They don't speak about interposition. They force to have a stapedotomy, but they don't force to have to have interposition. Yeah. It needs to be like this. They have to stop flying for 1 year. They have to have some examination before and after, and then they could fly back. That's interesting because it's official. So you're not going to talk this afternoon, too.
So the summary, as in the last 17 years, is we don't know. Right, okay. What are they in Wales? Sheep's intestine.
Thanks, John. It's an interesting question, this seal, because if you're looking at a fibrotic seal, what you're asking is not only that it goes round the circumference, but it also goes underneath the piston and forms an absolutely perfect seal. And when you take out one of these pistons, you usually just see a hole with perilymph in it. And it's a question of whether you can guarantee the integrity all the way around, which is quite a big ask.
You want to come back next
Well, so we haven't proved there's a problem. I mean, we're all arguing about this, and we've all admitted, we all have very strong convictions, but we can't prove them. Well, there's always saying that about my convictions. It's a hunch, isn't it? And a lot of what we do is a hunch.
I was going to say that, with the pilots, because we live in an area with a big military presence as well, with a lot of pilots and aviation people come to see us, and you can put them in a barometric, the fundamental mechanisms, the eardrum going in and out. You can also just do tympanometry and increase the pressure in the ear canal. And we've done that in some pilots to prove that they, by putting the pressure to double what they would experience in the aircraft, the external ear canal, that they did not get dizziness. And they demanded some kind of proof before we'd let them fly. But you can do that more easily with a tympanometer than putting in a diving chamber, unless you believe that's an explosive mechanism, it's actually the pressure inside the pneumal labyrinth, which I don't think it is. We've been asked to do that by Air Canada, but not an official policy that was their policy.
You see, we don't even have a policy about when you let patients fly. Nobody agrees about that. Some of the Americans fly them in and fly them out.
Do your Robert? Do your patients die sometimes? So that would be interesting to know whether
It's
what is
interesting.
happening.
Yes, some of them do. Some of them do. I always say it's better not to do it because I think it's no.
Die. They die.
Oh, die.
So at least then you can have a look and see what you have done.
That was a nice
You
trap.
said yes.
Thomas,
I would
Thomas.
say, yes, sometimes,
when they have the
Do you have any slices
But
or
Thomas,
any
when they have the vein graft-
histological sections of
Oh
post-mortem?
yeah, Elenticom has done that in House Clinic, I think.
With
showing the
interposition?
scans. Yeah. I think so. Yeah.
But do you not know, Thomas,
No,
when they have the vein graft, they don't die.
So do you think it's time we went and discussed this over lunch because you've had a long morning, and then we'll start promptly again this afternoon?